Hi, everyone, and welcome to another Facebook Live broadcast with MedStar Health. My name is Sarah Ridenour, and I'm joined today by hip and knee replacement specialist, Dr. Thomas Ring. Today, we're going to be talking about the lifespan of joint replacements. As people live longer, it's natural to wonder, am I going to outlive my hip or knee replacement? The technology is evolving, and this may have an impact on when patients decide to undergo surgery. Will a revision eventually be necessary? Is it worth getting both knees done at the same time? The timing of joint replacement can be a big decision. So if you're dealing with pain or arthritis in your joints, then stick around, share this broadcast with your friends, give us a like to let us know you're watching, and ask your questions for Dr. Ring in the comments below. Dr. Ring, welcome, and thank you for joining us. We appreciate you being here. Before we begin our discussion, could you tell our viewers a little bit about yourself and your specialty?
Okay, so my name is Thomas Ring. I'm a hip and knee replacement specialist here at Union Memorial in Baltimore, and I'm really underneath all of this. I'm a carpenter, right, or an engineer, a watchmaker, depending on how you want to look at it. Unlike a lot of other situations in medicine, most of the time my patients are not sick. They're either broken or they're worn out, and so my job is basically that of a structural engineer to diagnose what it is that's going on and then do whatever is necessary to treat that, and hopefully in doing so alleviate patients' pain, allow them better function and better overall quality of life.
Awesome. Well, thank you so much again for joining us, and let's get into the questions. So first of all, we'll start with, what are the typical signs and symptoms that someone should start considering that for a joint replacement?
So a great orthopedic surgeon once told me that everything in orthopedics comes down to pain and function. So that's really the two places to start. One is pain, pain in the joint, and especially when it's activity related, combined with function or lack thereof. So if someone's having difficulty walking versus getting up and down the stairs, or trouble sleeping at night, those kinds of things can all play a big role into what needs to be evaluated. If someone's pain is pretty mild and functionally they can do everything that they need to, those are often, as an orthopedist, those are typically best left well enough alone. But when the magnitude becomes greater and more of an impact on someone's lifestyle, then that's when it's reasonable to seek further investigation, let's say.
Mm-hmm. And can you explain a little bit the basic anatomy of hip and your knees, so we can understand exactly, what is getting replaced?
Sure. So they're both synovial joints. So the fundamentals of a synovial joint is that you have two bones that have cartilage covered surfaces that are contained within a capsule and surrounded by synovial fluid. The hip is primarily it is a ball and socket joint, and the knee, to an approximation, you can think of as a hinge. It bends back and forth in around one axis. And with arthritis, it's the cartilage that wears out, just as when you look at the end of a piece of raw chicken. It has soft, glistening cartilage that covers the end of the bone. In arthritis, for whatever reason, that cartilage starts to wear out, and that's the process of arthritis, is the wearing out of the cartilage. When it functions properly, cartilage is great because it doesn't have any nerve endings. That's why you don't think about it when you move your arms and legs around. You don't think about the fact that they're moving through space. There's not any direct innervation on the end of the bone. But when that cartilage wears out, the end of the bone is very heavily innervated. And when it reaches the point of someone has bone-on-bone articulation, a bone-on-bone joint, that can be intensely painful for patients.
Okay, thank you for explaining that. And like we said earlier, today we're talking about the lifespan of these joint replacements. So for context, can you establish the typical life expectancy for people?
Sure. So in the United States, the average life expectancy for women is about 80 years, and for men, it's about 74. And obviously, that's an average. And when it comes to joint replacements, so the average age of someone to have a joint replacement is typically going to be somewhere in the 66 to 68-year-old age range. So again, on the average, that's going to be about 8 years in a man, and on average, about 12 to 14 years in a woman. There are certainly exceptions to that. There are had plenty of patients that live into their 90s. I've had plenty of patients who have their joints replaced at earlier ages than 66 or 68. Patients in their 50s are pretty common. Patients in their 40s are more rare. Occasionally, my youngest patient to have a joint replacement, I've had 2 patients who were 28.
Oh, wow.
And it's the sort of thing that you look at the situation, and while it's not ideal by anybody's gauge, it's the best, it's the best alternative to, you're certainly not going to take somebody who's 28 and otherwise healthy and tell them to just go on disability and use a wheelchair for the rest of their life.
Right. And so then with that, what is the typical life expectancy of a knee or hip, the hardware when you do these replacements?
It's a great question, and it's one that I hear and answer all the time in the office. And historically, there are lots of patients have been told, oh, your hip replacement or your knee replacement, it'll last about 10 years and then you have to have it redone. Some other times people are told it'll last 15 years, but they don't really work that way. It almost makes it sound like they're tires, right? You go 10 years or 100,000 miles, and then your time's up and you come in, you get the parts swapped out, and then you start over. But it's not like getting a set of tires changed. It's more over time. You would expect to see, and this can take a little bit of explanation, but you would expect about 1% each year will have something wear out and require another surgery. So it's always hard to make individual predictions, but you find trends in groups. So let's imagine we have 100 patients who all have their hips replaced this year in 2022. We'd expect 10 years from now, in 2032, approximately 10 of them will have had a second surgery. 90 of them will not. So about 20 years. So we go out to 2042. At that point, you would expect, as an estimate, about 20 out of 100 will have had a second surgery, and 80 out of 100 will not. Now, after 20 years, where the average age is 66 to 68 to begin with, many of those patients have passed away, right? The life of the implant has lasted for the rest of the patient's life. You certainly still consider those a success, right? Because you've done one surgery that lasts the rest of the patient's life. Ultimately, that's the goal, or should be the goal, of any surgery, is to try and make it last as long as possible. Are there lots of patients out there with hips and knees that are 20 years old? There are quite a few of them out there. And they're some of them, I saw one today who had a knee replacement done 17 years ago. And that's just one that was coincidentally in my office an hour and a half ago. But there are plenty of patients out there who've had joints that have been in for 25 years or more. And that 1% a year ends up being a pretty good estimate over time. The reasons why they wear out.
Oh, I'm sorry.
I'm going to say,
go ahead.
Why they wear out, and that changes throughout time. If it is something in the first couple of years, that's typically going to be something that happened around the time of surgery, or it ends up being a fracture because somebody had a fall early on after surgery. As it starts getting further out from surgery, then it becomes more likely that it's a situation where the implants have worked loose or something like that.
Okay. So then this kind of connects to a question that we got from one of our viewers, Amy. She mentions that her father-in-law has had 3 hip replacements. Actually the first one was in 73 and the second one was in 93. So that's 20 years, like you were just mentioning. And then the third one was shortly after that second one. So her question was, is it possible to have multiple replacements? And I guess it is, but it's not, a definite thing is what you're saying.
It certainly is possible. And it really gets into the nitty gritty of what the initial surgery was and what the revision surgery was, especially when it comes to the hip. Oftentimes it's only one side that wears out and not the other. So there are many situations where you keep, for example, the femur, but replace the acetabulum, or vice versa. There are some situations when both have to be redone, but it really depends on which parts were replaced. In the knee, it's more common that all of the components get replaced with a revision, but even then, it's not always the case. Historically, so if you go back anything beyond about 20 years ago, one of the weak links in joint replacement was the plastic, the polyethylene. And over time, that would wear out and it would generate these little particles of plastic that the body would see and treat as foreign material. And to be fair, it is foreign material, but in some cases that would cause the bone to be eroded away around the metal parts that were fixed to the bone. More recently, so it was about 15 to 20 years ago, is when the modern formulations of plastic started to be used widely. And with those modern plastics in place, that issue where the plastic wears out tends to be much, much, much less common over time. That said, there's still a number of joint replacements out there that were done with what at the time was state-of-the-art plastic, but we expect to have a more limited lifespan over time.
And that actually answered my next question, which was talking about historically how joint replacements evolved. So then we actually have another question from a viewer, Angela. She asked, how long can we expect knee replacements to last, which we've covered. But then she also says, what kind of problems will be signs, what kind of problems or signs will show that we need to get another, second replacement done?
Yeah, so most of the time, there's going to be some sort of pain or abnormal function, some sort of dysfunction of the implant. The number of reasons why joint replacements can wear out, they literally fill textbooks, but they can be summarized in just in a small number of points. One is that they work loose over time, so they're no longer fixed solidly into the bone. A second would be infection, and that can be infection at the time of surgery, or it can be many years later. If somebody has an infection in an unrelated area of their body that somehow gets into the bloodstream and then settles on the joint replacement. Anywhere else in the body can fight off infection. But once infection gets onto a piece of metal, the body can't fight it off very effectively there. So that's the second one, is infection. Instability. So that would be, for example, something like the dislocation of a hip, which happens in about 1%, maybe a little less, of hip replacements afterward. Fracture is another one. And the fracture tends to happen really in two time frames. The first is early on after surgery. Somebody's trying to walk without their cane or their walker. They're trying to do too much too soon. They stumble for whatever reason, and then they have a fall early on after surgery. The second is much later, so maybe 10, 15, even 20 years after somebody has had a joint replacement. Everything is functioning fine, but their bones over time have become osteoporotic. They fall as many elderly patients do. And instead of breaking their own native bone, they break around the hip replacement. The implants, the metal for a hip replacement almost never breaks. I mean, I maybe see one every other year. It's not very common at all for the metal of the hip replacement to break, but what is more common is as a patient's bone becomes more brittle with age, if they have a fall, then they tend to break around the metal of the hip replacement. I mentioned the plastic wear as another potential reason why knee replacements can wear out. And those are going to be the most common ones, most common reasons for someone to have a revision of a knee replacement. It's not a comprehensive list, but it's a pretty good start.
Yeah. Well, thank you for explaining that, and thank you for your questions. Next question is, if you could explain the different types of joint replacement surgeries.
Sure. So why don't we'll do the hip first.
Okay.
Hip replacement, really, they're only really, I'll say, two current options with one that's more historical. So the two current options, partial hip replacement and then total hip replacement, are the two that are used commonly. A partial hip replacement replaces the head ball, but not the socket.
Mm-hmm.
And the only time that that's really appropriate is in an elderly patient who falls and has a fracture of their femur.
Okay.
In that situation, the best treatment for the fracture itself is literally to take it out. So you replace the broken portion of the bone with a hip replacement on the femur side. The cartilage that's on the acetabulum, the cartilage of the socket, is still usually in pretty good condition. And so that gets left alone.
Okay.
So that's the partial hip replacement. That really only happens in the fracture setting. So it's not something that patients have when they have a long, slowly have a hip that's getting worse from arthritis, because pain of arthritis, the process happens both on the socket side and on the ball side of the femoral head. And then the one that I made the historical note, so that in the past there was a procedure called a hip resurfacing. Mm-hmm. And really a hip resurfacing is another form of hip replacement, but has a different form on what's attached to the femur. It's not as extensive. It doesn't go into the center of the femur the way modern hip replacement implants do, but rather just puts a new cap on the top of the ball, which it's a good procedure. But what we've seen over time is that there on occasion can be some problems with it. Mm-hmm. And in the long term, it's not as good as a hip replacement, just a conventional hip replacement. And it primarily has to do with really two things. One is the articular surface of a hip resurfacing is always metal against metal, which is something that we've seen since about 2009 to cause problems in a percentage of patients. It's certainly not everybody, but in a percentage of patients, the metal on metal articulation can be a problem. And the second relates to what I said earlier about the bone over time becoming more brittle. And because the hip resurfacing only replaced the head portion and it doesn't do anything for the neck, patients can have femoral neck fractures because that hasn't been substituted for in the same way it is when somebody has a more conventional hip replacement. So hip resurfacing is out there, but there are very, very few of those done any longer, because simply over time we found that hip replacements have performed better.
Right.
Switching over to the knee. So in the knee, there are total knee replacements and there are partial knee replacements. Mm-hmm. And the partial here is different than the partial in the hip. The partial in the hip is only on one side. I made the analogy of a hinge for the knee earlier. A partial hip or a partial knee replacement, you can think of as replacing both sides of the hinge, but only on one portion of it. Okay. The hip for the hip, it would be more replacing one end of the hinge, but not the other, if that makes sense. partial knee replacement is both the femur and the tibia wearing out, but only in one particular region of the knee. We break up into three areas: the medial side, the lateral side, and then what we call patellofemoral, which is the area behind the kneecap where the kneecap glides over the end of the femur. When the arthritis is primarily in one compartment and the other two compartments look okay, then a partial knee replacement is an excellent surgery, primarily for arthritis. That's one that, unlike the partial hip replacement, that's not a patient that, that's partial hip replacement is always due to a fracture. A partial knee replacement is often somebody who comes into the office because slowly over time their knee has gotten worse. Certainly the most common is going to be medial compartment wear, which is when somebody has a tendency to be a little bit bow-legged and they wear out the femur and the tibia only on the inside of the knee, but the outside still looks good, and the part that's behind the kneecap still looks good as well.
Thank you for explaining all that. That's a lot of options. So how does a patient decide which one is right for them? I assume that's a conversation you have with them, or is it, just...
That's a conversation I have every day in the office, many times a day in the office. And it's taking the individual patient and what their symptoms are clinically, where they are having their pain, combined with where their arthritis is on the x-ray and where it is not. If somebody has arthritis all throughout the knee, then a partial knee replacement is not a good option there because it leaves too much of the knee untreated. If all the arthritis is just in one spot and the rest of the knee looks pretty good, then partial knee replacement is an excellent option in that sort of situation. But there's not a blanket answer for that.
Right.
But it's something that I talk to patients about pretty much all day, every day if I'm not in the operating room.
Oh, exactly. Well, thank you for explaining that again. And if you're just now joining us, thank you for tuning in. Today, we're joined by hip and knee replacement specialist, Dr. Thomas Ring. We're talking about the lifespan of joint replacements. As people live longer, it's natural to wonder, am I going to outlive my hip or knee replacement? Technology is evolving, and this may have an impact on when patients decide to undergo surgery. Will a revision eventually be necessary? Is it worth getting both knees done at the same time? The timing of joint replacement can be a big decision. So if you're dealing with pain or arthritis in your joints and want to learn more, we have a lot more to talk about, so stick around, share this broadcast with your friends. Give us a like to let us know you're watching, and if you have any questions for Dr. Ring, you can leave those in the comments below. So back to what we were just talking about, how do you typically diagnose a patient? I know you said this is something you talk about every day. What is the exact process? Is there different tests you do, or how does that work?
90% of the time or better, all we need are the patient and x-rays. It's the other 10% is less common, but those would be the situations where we need to get a little bit more information. Usually that's going to be with an MRI, occasionally with a CT scan, or occasionally with a bone scan. And that's more, the bone scan really only comes into play if somebody's having problems after having had a knee replacement done. It's almost never needed if somebody still has their native knee with their native cartilage.
And we actually have a question that I'm going to ask real quick from one of our viewers, Gail. They ask, does knee replacement remove all pain, and can you get back on your knees quickly after surgery? And she also asked, you mentioned metals. She asked, I've heard metals can be poisonous. Is that true?
Let me go to the second question first.
Okay.
So can metals be poisonous? In theory, yes. We don't, the places where we occasionally see it in joint replacements is it's almost never a metal toxicity type of situation, similar to when somebody ingests something, or miners or something like that, where they have really high levels of metal in their body. But with those, I mentioned the metal on metal articulation. Those in the past have caused some issues with fluid collections and other, erosions of other anatomic structures in the area of the hip. The way to get away from that is to avoid the metal on metal articulation.
Mhm.
And that's why hip resurfacing is not done very often anymore, because when you eliminate the hip resurfacing, then the articulation surface that you have is going to be either a ceramic head ball against a plastic liner or a metal head ball against a plastic liner. And those both have less of a tendency to generate metals. There's a small amount of metal that can be generated with a metal head ball and a metal stem.
Mhm.
It doesn't happen at the articulation, but rather where the two parts are connected together. That's uncommon. It's maybe 1, maybe 2%. And the way around that is simply not to use a metal head. That's why in my own practice, and I think many other practices around the country have moved to almost exclusively ceramic head balls.
Okay.
And so even though there's metal on the stem, there's metal in the socket, none of it is articular. It doesn't grind or move against anything. And second, it doesn't have any interfaces with other metals.
Okay.
So by doing that, it seems to eliminate the problems with metal poison or metal toxicity.
Okay.
I've already forgotten what was the first question.
I was going to say her other question ties into something that I was going to ask later on, but we can get into it now. She was wondering, does knee replacement surgery or knee replacement, does it remove all pain? And can you get back on your knees quickly after surgery? Which kind of leads into my question of what does recovery look like for patients who get knee and or hip replacements?
Sure. So knee replacement is a very good surgery to alleviate pain and improve function that's due to arthritis. But it's important to recognize it is not a perfect surgery. There's no surgery that can give a patient the knee that they had when they were 30 years old.
Mm-hmm.
Patients have less pain after they've gone through the recovery process and better function, but it's uncommon to have completely 100% all pain go away with a knee replacement.
Mm-hmm.
Just as it's not realistic to have perfect function after somebody's had a knee replacement, which is not just, it's just a matter of having the right expectations after surgery. I've had many patients who they can play tennis. I have one patient who is a very aggressive skier and then had both knees replaced, able to get back to skiing doing what he wants to do. But if you ask most people, they can still tell you little ways that they can tell that their knee replacements are different than the knees that they had when they were 30 years old. So does knee replacement help with the pain? By and large, yes. And it helps quite a bit, but it's not, I never tell patients that it's going to take away all of the pain that you have.
Right. Right. Thank you. And thank you for your questions, Gail. My next question for you is, so I feel like it's kind of, at least I've known people who put off surgery, for years or whatever, only to say afterwards that they wish that they had done it sooner. Is that common, something that you recognize happens a lot? And what would you say to those people who are maybe putting it off? Would you agree that it's better to get done sooner rather than later?
I do hear that fairly frequently.
Mm-hmm.
And it's, in most cases, joint replacement is elective surgery. It's not something that anybody has to do. The one situation where I'll kind of nudge people and say, you probably should do something sooner rather than later is going to be those patients where, for whatever reason, their knee is so arthritic or their hip is so arthritic that it's given out or it's buckling or other one way or another, it's causing them to fall, because those are the patients that they're going to, somebody's going to fall and break a, have a bad knee, they fall and break a hip. They've got a bad hip, they fall and break an ankle, or they end up with a vertebral compression fracture in their back or break a wrist. Those kinds of things, when the joint gives out, to me, that's not a red flag, but at least a yellow flag that we need to do something sooner rather than later. For the patients who are stable on their feet, where it's a matter of pain, often they do, when they go through recovery and they say, yeah, I wish I had done this sooner, that's still their call to make. I don't try and make any promises that I can't back up. And I tell people frequently that if you're still on the fence, that's fine. If you're still on the fence, that's probably a sign that you're not quite ready yet. And ultimately, they decide when they're ready. There are a few circumstances where, if I look, and this is mostly a radiographic and X-ray assessment, if I look at it and I think, if we wait too much longer, things could get worse in a way that either make surgery harder or make their ultimate outcome not as good, then I'll typically let them know that. That's never a matter of days or usually even weeks. That's usually more along the lines of, we can't leave this alone for 5 years, that kind of thing.
Right. And so is there anything that people can do to delay or to prevent joint replacement? Or is that kind of just something that you either need one or you don't, sort of thing?
So the two biggest things are, the first is avoiding injuries when they're young. And the second is maintaining a healthy weight throughout their life. One thing that commonly happens, somebody has maybe an ACL tear or a bad meniscus tear when they're young. Again, you can't predict individuals, but as a group, those are the patients who are going to go on to have arthritis earlier in their life than they ordinarily would if they never had their ACL tear, never had their meniscal tear. With the weight, I mean, if there's one thing that's been consistent over the last, 20, 30, 40 years, it's that as the obesity rates in the general population have increased, the amount of arthritis has also increased a lot. There are more joint replacements done now in 2022 than at any time in the past. And a lot of the increase is driven by patients carrying around extra weight for not just years, but decades. So yeah, maintaining a healthy weight is probably the single most important practice for people who want to maintain and keep their joints for as long as possible.
Right. And you mentioned having an ACL tear and that affecting your need for knee replacement later down the road. We have a question. Robin asked, does a knee replacement make the knee more stable if you already have no ACL or MCL? Can you talk about how that connects too?
So it generally, yes. And there's some sort of especially with the ACL, there's a little bit of a caveat here in that no widely used knee replacement has an ACL. In a partial, the ACL is preserved, but in a total knee replacement, the ACL is removed. And the only time that doesn't happen is the experimental knee replacements that have yet to prove that they are feasible and that they work well and that they last. That said, there are things that you can do at the time of surgery to make the knee more stable. Not that it's going to directly reconstruct an ACL, but it gives the patient a stable knee that they can go through life with. With the MCL, there are a number of different things that you can do at the time of surgery, either to compensate for an MCL that was torn in the past, or to substitute for it if the MCL is completely shot.
Right. Well, thank you for your question, Robin. My next question for you, if arthritis tends to get worse as we age, how often do patients need to get an additional joint replacement to the other side of their body, or how common is it, to need a hip replacement after you've gotten a knee? How does that all connect?
So it depends on how long somebody lives, certainly. But it's going to be in the ballpark of about 1 in 3 to 1 in 4.
Okay.
So certainly having one joint replacement is not a guarantee that somebody's going to have the exact same thing happen a year or even a decade down the road. But it's fairly common. So yeah, 1 in 3 is a pretty good estimate.
Okay. And then is it possible to get both knees replaced at the same time? And if so, what are the pros and cons of doing that?
Yes, it's certainly possible. So the pros are you only have one recovery period. You only go under anesthesia once. And the primary reason that people do it is usually work related. They only want to take off work one time to recover and then get back and not have to talk to their boss about taking another period of time off from work. So yeah, that's the benefit, is it all happens at one time. The downsides, it is more challenging for that, especially the first month. It can be more challenging. Generally, by the end of the first month, people are getting pretty well back to where they would be if they just did one at a time. To get somebody directly home after surgery is almost a guarantee if you do one knee at a time. But if somebody has both knees done, right, this is the person that doesn't have a good knee to stand on. Some of those patients are able to go home, but in other cases, they need to go to an acute rehab facility to get stronger for a week or 2, or sometimes 3, before they can go home from there. So if that's something that's critical to somebody, then I just tell them we'll break it up and we'll do one and then we'll do the other. Usually 2 or 3 months down the road. Needing a blood transfusion is about 0 if somebody has one knee replacement done at the same time. If they have both done at the same time, since they're 2 episodes of blood loss, one right after the other, without any chance for the body to recover, there's more likelihood that somebody needs to have a transfusion there, but it's, I don't know, maybe 25%.
Okay. And then what should patients, what is the long-term outlook for patients when they get these surgeries? Do they need to make any lifestyle changes, I guess, to help preserve the replacement and help it last longer, or anything like that?
I only give people a couple of restrictions. The first is I don't generally recommend long distance running, training for marathons, 10Ks, those kinds of things. If people are going to be jogging short distances, I don't restrict that. If somebody wants to referee football games, that's not a problem. They're certainly allowed to do that. If somebody needs to, catch a bus, you can run and catch the bus. That's not a problem. But I generally try and steer people away from truly long distance running and try and direct them toward elliptical, bicycling, swimming, something that's going to be a little bit lower impact. I don't generally recommend any sort of really high impact, either high impact aerobics or plyometrics, simply because of the impact on the joints. And then for hips, when patients do yoga after a hip replacement, we have to talk about what positions are more at risk for causing a dislocation than other positions. I haven't had a patient who dislocated a hip doing yoga, but I don't want to have one. So
Exactly.
those are the patients who we just have to talk about what exercises are you doing, and let's make sure that you do them safely
Right.
so that you don't cause some sort of problem by twisting yourself into a pretzel.
Right. Exactly. I would be perfectly fine with not having to do any long distance running. That is okay with me. Um, my next question. So you mentioned earlier, we kind of talked about how um, knee replacement and hip replacement surgeries have evolved over time. So is there any new technology on the horizon to keep evolving this? And what type of joint replacements might we see in the future?
The new kid on the block, so to speak, is robotics, and robotics have to do with how the knee replacement is put in. So when you make the cuts on the end of the bone, you use robotics to help optimize those to put them exactly where you want it. The implants themselves haven't changed significantly. I mentioned the plastic was changed about 15 or 20 years ago. That's really been the most recent material change of great significance. Looking ahead, whoever figures out how to cure arthritis or treat arthritis in a way that can undo the arthritis process, I'm convinced is going to win the Nobel Prize.
Mhm.
Because it's such a widespread problem, and we've made frustratingly little progress on that over the last several decades. Contrast this actually to the rheumatologists have done a really good job with the newer rheumatoid arthritis medicines.
Mhm.
The surgeons that trained me, the ones that are now in their 70s, in those days when they were going through their training, half of the hospital ward, at least half of the orthopedic ward, was patients with orthopedic manifestations of rheumatoid arthritis. And those have almost completely gone away with the newer rheumatoid arthritis biologics, with the Humira type medications. I wish I could say there's something coming down the pipeline soon that's going to do the same for wear and tear osteoarthritis, but I don't see anything coming soon there. Technology and joint replacements is something that, because we've got something that's so durable as is, you want to be kind of slow to make changes. You don't want to be adopting every new bell and whistle, because those are the ones that you find out what looks good now, 2 to 5 years from now, may not hold up nearly as well as other more proven technologies.
Yeah, and you mentioned robotic surgery. We actually had two of our viewers bring up robotic surgery. Doreen mentions that she had a robotic total knee replacement 6 months ago and completed her PT successfully, but she has some pain on the outside of her knee, and the x-rays show that everything is okay. What could possibly be causing this pain? Do you know, or is that something that you have to?
That's something that I can speak only in generalities about, right? To truly assess that, I'd have to meet the patient in the office, examine their knee, look at the x-rays myself. But is there an issue with the implant? Is there a soft tissue tendonitis or bursitis type condition? Issues related to people's backs are very common in the age range where patients are having their joints replaced. That's a little less common in the knee, but very common when patients have pain around their hip, where their back is really what's driving a lot of the symptoms that they're having.
Okay. And then the other person who mentioned robotic surgery, Monomed, asks, how do you feel about customized knee replacement parts? And also, how do you feel about the use of robotic surgery?
So I'm a proponent of robotics. I generally will use it in patients who are younger, more active, and have good bone. I tend not to use it in patients who are older, less active, and if I have any concerns about the quality of their bone, those generally are not patients where the robotics are worth. It does add time in the operating room. In those cases, it's generally it simply doesn't add anything other than making the surgery longer. But for the younger, more active patients, I do think it's a helpful tool to have there.
Okay. Well, thank you. And thank you all for your questions. My final question for you is, in conclusion, what do you want people to take away from this conversation about joint replacement?
So as patients get older, there are lots and lots of patients who have pain in their hips and their knees, and other joints for that matter, that are caused by arthritis. And there are lots of things that we can do to alleviate that pain, improve their function, and overall give them better quality of life. Obviously, we start non-surgically. If I can get somebody better without operating on them, that's a big win. And when that doesn't work, and we can talk about surgical options, and with arthritis, there are lots of good options that are proven and have good track records, that while I'd like to say that they're 100%, they're not 100%, but they do hold up very well over time.
Yeah. Well, that's a perfect way to wrap up this broadcast. Thank you so much again for joining us and answering our questions. We appreciate you taking time out of your day to do that.
Happy to
And
do
thank
it.
you to our viewers for asking your questions and tuning in. We actually have another question from a viewer who wants to know if you're taking new patients. And to that, I say, if you want to schedule an evaluation with Dr. Ring, you can call 877-34-ORTHO. We'll also be posting that number in the comments below. And we look forward to seeing you guys again.
Okay,
Thank
great.
you.
Thank you very much.